Are you experiencing a sharp traveling discomfort starting in your lower back and shooting all the way down your leg? If you are, I want you to know right off the bat, your pain is entirely valid and you are definitely not alone. It can be an incredibly distressing, exhausting experience that might even make you feel like your life is completely on hold right now. But there is a path forward, and today we're going to walk through it together. Okay, let's dive into this. Welcome to our explainer on demystifying sciatica. I'm here to provide you with a clear, evidence based roadmap for understanding exactly what is happening in your body and, more importantly, how we're going to resolve that discomfort. Think of this as your personal guide to taking back control of your health. Here's our roadmap for today. Number one, understanding sciatica. Number two, common causes. Number three, expected resolution. Number four, escalation of care. And number five, red flags. Section 1. Understanding sciatica and radiculopathy. When you visit a clinic, your doctor might use the term lumbar radiculopathy. It sounds complicated, but it really isn't. Notice the lumbosacral nerve pathways here, specifically those labeled L4 through S1. They travel from the lower spine all the way down the legs to the feet. Sciatica happens when there's inflammation or mechanical compression of these specific spinal nerve roots. Because these nerves act a lot like electrical wires running down your leg, a pinch up in your lower back can send a sharp shooting true radicular pain traveling all the way down that specific nerve pathway. Now, the really crucial point here is making sure we accurately identify what type of pain you're actually having. Is it true radicular pain or is it referred pain? True radicular pain or sciatica is characterized by pain that shoots specifically below the knee. It's often accompanied by numbness, tingling, or even muscle weakness because the nerve's ability to conduct signals is literally impaired. On the flip side, referred pain is typically a deep, dull ache that stays restricted to the lower back, the buttocks, or the hips. Knowing the difference is step one in getting you the right care. Section 2. The most common causes. Let's look at why this nerve compression actually happens. The most frequent culprit is a herniated disc. To demystify the clinical jargon a bit, imagine the discs between your vertebrae as fluid-filled shock absorbers, little cushions. They have a tough, fibrous outer layer and a soft, gel-like inner core. Because of wear and tear, or maybe a sudden strain, the outer layer can develop a tear. This allows the inner gel to bulge outward. When that material bulges into the spinal canal, it doesn't just physically press on the nearby nerve root. It also releases inflammatory chemicals. That combination, mechanical pressure plus intense inflammation, is exactly what triggers severe leg pain. So, what kinds of things place excess strain on your spine? We can think about risk factors in two ways: the fire and the kindling. The direct causes, or the fire, include things like disc herniations and spinal stenosis. Spinal stenosis is simply a narrowing of the spinal canal that commonly occurs with aging. But the kindling, the physical and lifestyle factors that set the stage, include heavy manual labor, frequent bending, repeated lifting, and prolonged driving. Smoking and a high body mass index have also been shown to significantly accelerate these degenerative processes. Section 3. Expected resolution and timeline. I want you to take a deep breath right now because this is the most reassuring information in today's explainer. 90%, a massive 90% of patients with acute lumbar radiculopathy improve with non-operative treatment. That means 9 out of 10 people recover without ever needing spine surgery. Your body has an incredible capacity to heal, and the inflammation around that nerve root will often subside on its own over time to provide even more reassurance. Studies show that with proper conservative management, the average time to return to work and daily activities is approximately 5.8 weeks. You are not looking at years of disability. For the vast majority of people, meaningful improvement occurs over weeks, not years. A typical treatment timeline looks something like this, from week 0 through week 6. The focus is conservative treatment, relative rest, anti-inflammatory medications, and physical therapy. Physical therapy often focuses on activating the deep core stabilizers, including muscles such as the multifidus. If symptoms persist beyond 6 weeks, that's when we may consider a selective nerve root corticosteroid injection. This delivers a potent anti-inflammatory medication directly to the irritated nerve root, helping calm stubborn inflammation. Section 4. When symptoms do not resolve, it's completely reasonable to ask, what if my pain doesn't get better? Here's how we logically escalate care. If symptoms have not improved after 6 weeks of dedicated conservative treatment, step 1 is usually obtaining an MRI. Unlike x-rays, an MRI allows us to clearly visualize the soft tissues. It helps us determine whether a herniated disc is truly compressing a nerve root, Once we confirm that the anatomy matches your symptoms, step two may be an evaluation for surgery, most commonly a microdiscectomy. In this procedure, the portion of disc material compressing the nerve is carefully removed. However, it's important to understand the role of surgery. While surgery often provides faster pain relief early on, research consistently shows that long term outcomes between surgical and non surgical treatment become very similar. For that reason, surgery is generally reserved for patients with severe symptoms, failure of conservative treatment, or progressive neurological weakness. For example, if you suddenly develop difficulty lifting your foot while walking. Section 5. Red flags requiring immediate medical attention. I need to shift gears here and adopt a much more serious tone. While most cases of sciatica are highly treatable, we are always watching for a rare emergency called Kada equina syndrome. This occurs when the bundle of nerve roots at the bottom of the spinal canal becomes severely compressed. Red flags include saddle anesthesia, meaning numbness in the groin or perineal region, the area that would contact a saddle if you were riding a horse, new bowel or bladder dysfunction, loss of urinary control, loss of bowel control, rapidly progressive weakness in the legs, or pain that becomes completely unmanageable. If any of these symptoms occur, you should seek immediate emergency medical evaluation. Prompt treatment may be necessary to prevent permanent nerve damage. To wrap up today's explainer, I want to leave you with a question. Are your symptoms changing? Is the pain traveling farther down the leg, or is it beginning to retreat back toward your back? You are the best expert on your own body. Pay attention to those patterns. Keep a symptom journal. Bring your questions to your physician. And remember, 90% of people overcome this. There is a roadmap, there is a plan, and there is every reason to be hopeful. So, what's your next step?